Today, I would like to share a very unique case of 58 years long blindness, which was resolved by artificial cornea. The patient is today 70 years old man who got blinded in 12 years by hot liquid. He subsequently underwent 20 corneal transplantations. After some of them, he was able to see a few weeks up to a few months. He is also pseudophakic in both eyes, but most of his life after this injury he was blind and he worked as a piano tuner. 10 years ago, I implanted him artificial cornea Boston K-Pro, and he could see for about 2 years. And unfortunately, someone terminated his local antibiotic drops, which resulted in subsequent endophthalmitis, which damaged his retina, and he was blind again, and he remained blind for the next 8 years. After the recent 8 years of blindness, this man finally decided he would like to undergo another artificial cornea transplantation on his right eye. This is his right eye, and you can see that this is not going to be an easy surgery. It's quite a challenging eye. This preoperative OCT reveals 1 mm thick cornea and anterior synechia. Based on this OCT, we decided to use his own cornea to retain the new artificial Boston K-Pro keratoprosthesis. Let's have a look at the video from this surgery. This is the eye before the surgery, and because of extensive symblepharon, it was not possible to insert the speculum, so we sutured the speculum on the skin on the lower lid. Here we see how we fixed the speculum to his lower lid, and it was possible to insert the speculum under the upper lid. We perform a radial corneal mark because we want to use his own cornea for the surgery to retain the new artificial K-Pro. So this radial mark will help us with orientation. Cauterization of the main vessels at the limbus helped us to reduce the bleeding. And the next surgical step is trephination. So we trephine his cornea all the way through. And as soon as we seen the aqueous coming out of the eye, I took the curved scissors to cut the cornea, but we also needed to cut the anterior synechia with these scissors. And based on this OCT picture, we knew that anterior synechia are quite extensive. Of course, we do not want to pull the iris together with artificial IOL out of the eye, so that's why I use the scissors to gently detach his cornea from the other tissues in anterior chamber. So we are coming towards the next step, which is preparing the artificial cornea, fix it, and now we are going to suture the complex of artificial cornea with his own cornea to his eye. The first suture we need to tight, and then we will need to suture the cornea opposite to the first suture, and as soon as we have the first two sutures tight, I can rest a little more because the danger of severe complications is now a little bit lower, and we can put all the sutures around the circumference of this complex of his own cornea and his artificial cornea. Now I tilt this complex to be able to clean the bleeding in between artificial cornea and his intraocular lens, and I place a third suture on this eye. I use single sutures, interrupted sutures. I don't like to use the running suture in cases of artificial cornea. Of course, we don't care about astigmatism here because the tension of the sutures does not correspond with astigmatism here because the optic is firm, made of PMMA. I usually tie the sutures 1, 1, and 1, and as soon as we have all the sutures around this eye, I can start to bury the knots because it's important to bury all the knots to avoid eye irritation after the surgery. This is a general rule in corneal transplantations, including the artificial cornea. We see some scarring tissue around the artificial IOL, so now we pressurize the eye, and I like to insert triamcinolone with anti-VEGF and cefuroxime intraocularly in such challenging cases. And now we need to remove the suture from the lower lid to remove the speculum, and this is the final picture of this eye. On the first day post-op, this patient could see 0.125, so both patient and we were super happy. And anyhow, the surprise might be that he still uses his white stick to help orientation, as his brain kind of forgot to see after that many years of blindness. This is a picture of this eye 6 weeks after surgery. We see a quiet eye which looks pretty nice, and the vision with -8 sphere ranks 0.3 decimal. So I think this is a really great result and a dramatic change of light quality and of course the visual quality of this patient. Here we see the retina of this patient. We see some floaters in the vitreous and optic nerve cupping, but the retina is quite okay, and therefore the patient can see 0.3. So in conclusion, artificial cornea can give vision to blind people, and that's very important. Of course, we need a patient or an eye with optic nerve and retina okay without severe damage. And after long blindness, the brain can forget to see, so the long-term visual rehabilitation can be expected. And one more additional information is that topical antibiotic drops needs to be administered for the entire time the artificial cornea is in the eye. Thank you for your attention, and this is a short video of our clinic taken by my own small drone after a busy surgical day. Have a great day.
So let's open the discussion.
So Pavel, I would have a quick question. That was a fantastic surgery, very challenging one. So I understood the patient was not a physician this time. I wondered if you have experience with other type of artificial cornea, because we heard about a lot of different artificial cornea and tissue engineering and so on. If you have some thought about this, if you already tried that, if you would like to try, I know that there is also kind of complex surgery with by using tooth of the patient. It's a kind of also very complex surgery. But do you have in your scope of alternative this in mind too?
Well, actually, my first case was with that tooth and the optic, osteoodontokeratoprosthesis. It's a complex surgery with a complex name. And it was just designed by Strampelli in Italy, I think 50 years ago or something like that. It works, but the risks are too high, and that patient was able to see for a few months. And also this patient, after osteodontokeratoprothesis, did develop endophthalmitis that time. And that came us to the idea to learn the Boston K-Pro surgery. And since that, I did, I think, something like 30 cases. But from my perspective and experience and my knowledge, this is the best artificial cornea. I know there is one developed in Israel also. We will see that. We tried something with the biosynthetic collagen, but it's a long way to get to artificial cornea. So I've been only using Boston K-Pro. And I think that's the best option at the moment, even though it's not the perfect artificial cornea.
That was a beautifully done case, Pavel, and I completely agree with you that artificial corneas and Boston keratoprosthesis do very well in many of these patients. I think, David, the reason you would not do OKP in this patient would also be because I don't think he had that amount of severe dry eye, right? It did not seem to be, when you have a wet cornea, you can still go ahead and do a Boston type 1 keratoprosthesis. It's only in the very dry cases like severe Steven Johnson's or, chemical burns and things like that, where you would go in for the type 2 or the OKP.
Having known the limitations of current Boston K-Pro, we have developed our own silicone artificial cornea, which can be inserted through 3mm incision only, making the surgery very easy and straightforward. And we plan the first clinical tests this year.
I just wanted to ask you a question, Pavel. That cornea which you excised, did you use the same one to implant the K-Pro in again?
Yeah, this case, the cornea was thick enough, so we took the advantage. We do it whenever we see a healthy, thick cornea. We take it out, find the central 3mm opening, put the K-Pro optic and the back plate in that, and suture it back to the eye. So that was this case.
Okay, that's actually quite interesting, because you do not you do not have to have the burden of already with difficulty in eye grafts obtaining, especially during the COVID time and things like that. This would have been very interesting. I was just wondering about the sizing. Would that cause any problem, because you would not oversize the cornea, right? It would be the same size, and would that result in any complications in terms of angle compression or things like that?
Well, I think we have done, a handful of the K-Pros with the patient's own corneas only. I think it was something like 5 cases. And these cases, I think, are doing even better than the cases with the corneas from the eye banks.
Yeah, but of course, in a Boston K-Pro, you do not need healthy cornea. You just need a carrier for the this thing. So I think that's a great idea. I haven't. That's actually the first time I'm seeing that being done, and I think that's really very ingenious use of the patient's own cornea instead of discarding that.
Thank you for that. And one of the risks of Boston K-Pro is that it does not stay long term in the cornea. The cornea gets thinner. I think it also is a result of the mechanical pressure, and therefore we developed our own backplate from hydrophobic acrylic, which we can use instead of the titanium original backplate. We have about 5 cases, and it looks again quite promising, but we of course need long-term data.
And that's very interesting. So you're using a hydrophobic backplate.
Yeah.
Okay. So what we get is a PMMA backplate, and that actually does pretty well as well.
But we used to have PMMA backplates from Boston K-Pro from Massachusetts, but then they changed to titanium. Which is not, it's not the most important aspect, but it's not looking that good as the transparent PMMA. But again, the hydrophobic acrylic material seems to be best from my experience.
Thank you. Thanks for sharing that case. That was very interesting.